Yeah, so it's quite a busy one, this, Ben. You've got a lot of people coming in.
Interesting.
So we usually just give it till 8 o'clock. It's got 3 minutes. It just takes a while for everyone to come on in. So how many kids have you got, Ben?
2. Samuel's 6 in November, and Beatrice is she's 8 in March.
Very nice.
We started with a load of homework this week, so
Doesn't get any easier. My daughter's going to uni in a couple of weeks.
What's she doing?
Civil engineering.
All right, where?
Bath.
Oh, beautiful.
Yeah, it should be good.
Good place for it.
Yeah, so we're Romina, what we were saying is I was talking to Eddie Jeans, my TIG fellow, and even though you think this is a bad time for training, and certainly it was during lockdown, there wasn't much going on, but what we're seeing now is because the lists aren't absolutely packed with 9 or 10 cases, there's 4 or 5 cases, it's an increased training opportunities, really, because you've got so much time on the list. So I think it will actually work out really well for people for the next year or two, just as decreased numbers of cases are getting done, decreased numbers in clinic, more time to talk, more time to teach.
Yeah.
So I actually think we should all perhaps look at it as a positive thing, really. And
Yeah.
certainly Eddie's doing a fair bit. I don't know if that's your experience, is it?
I think so too. I think we've got to take the positives rather than just keep looking at the negatives. It can be quite soul destroying. I think definitely some of the elective stuff, especially we're looking at a lot of regional block work under regional blocks like Dupotrons and things, is perfect for hands and upper limb. And there's always going to be hand trauma as well, which is a bit of a mixed bag. But I'm just missing more the implant work like CMCJ replacements or wrist fusions, that kind of thing. But hopefully that will come. But we're doing more soft tissue work under regional block in our satellite hospitals, which are technically sort of green zones. And that's certainly working well with Norfolk and Norwich, but not really in places like Addenbrooke's. I think it's getting, because I've just finished 2 years in Addenbrooke's and they were just still doing the old COVID rota. So they're a bit slow, I think, or getting the elective work up and running.
Yeah, there's big variation, isn't there, around the country, really?
Well, we've got a week worth of full elective capacity. 8 elective theatres working on a day-to-day basis.
Oh.
And
right,
so to shake a stick up.
Okay, so it's 8 o'clock, so we'll get started, and people will start to drip in.
Okay.
10 minutes ago. So welcome again. I've had a couple of breaks. Matt Ricks and Paneet Monga, my 2 colleagues, have been hosting for the last few weeks. It's great to introduce Romina Bigham from BOTA, budding hand surgeon. She's a TIG fellow at Norfolk and Norwich, and Ben Fisher, who's a trauma orthopedic consultant on the limb reconstruction unit at the Royal Liverpool Hospital in Broad Green. And it's really aged me. You probably saw it on Twitter that Ben was actually a medical student with me a long time ago, and we must have done a good thing to get him interested in this crazy business that we're all doing, which is fantastic. So I'm really looking forward to listening to Ben speak tonight. Romina, is there anything that you want to have a chat about from a BOTA side of things before we get going?
Just a reminder for everyone that the BOA Congress is next week, and to hopefully everyone's registered. We look forward to seeing everyone virtually. We are doing BOTA are doing a section in at the BOA, particularly looking at equality and diversity, but also sort of more pertinent for August 2021 or the upcoming year is the new curriculum. So we'll give you details about the new curriculum and updates on that from SAC and JCIE. That's the real news that hopefully all the trainees are aware of, and we'll hopefully be able to lighten a few more questions or address some queries during that session.
Right. So there's a few of you asking about, can these go up onto YouTube? I think everything's been recorded. The ones that Matt has done, he's recorded them and he's going to put them on YouTube eventually. Rheumatoid was last week, I think. This is gone on YouTube now. So that should be there permanently, although some of them have been deleted by YouTube in the past. So I'm sorry about that. We're not sure what's going on. Throughout tonight, if you could use the Q&A button rather than the chat button, it's just Romina will be looking at there. She'll be taking down 3 or 4 questions to ask Ben at the end of each of his 3 parts of this talk. So with no further ado, I'm going to hand you over now to Ben. And as I say, it's a great sort of personal pride, really, that the medical students come through and has become a really well-respected trauma surgeon. So over to you, Ben.
Thanks, Mike. Just want me to share my screen, yeah? Right, so very flattering introduction from Mike there. So yeah, as he says, I think it's longer than we both care to mention. I was his medical student. I think he taught me how to do carpal tunnels and stitch, which was quite entertaining. That I now ended up doing what I'm doing. So here we go. I'm a consultant orthopedic surgeon with a particular interest in major trauma limb reconstruction. I'm based in Luft at Liverpool University Hospitals Foundation Trust, part of the Major Trauma Centre Collaborative on Cheshire and Merseyside. And I'm now part of the limb reconstruction unit at Broad Green, having been a one-man band in Aintree prior to a recent merger. Details and declarations, if you want some more information about our unit and about the members of staff who serve that unit, look at www.limrecon.com. I have the Twitter hashtag at orthohexapod if anyone's interested. There's usually some arguments with American consultants about DHSs. Declarations, I am starting to do some consulting with Dupuy Synthes, and we have a fellow in the unit, part funded by Smith & Nephew and part funded by IdealMed. The aims tonight, we're going to look bone healing, some basic science. We're going to look at how you avoid issues with bone healing. Then we're going to go on to some basics around fracture fixation, really sort of aimed at getting you through the test if you're English or British, should I say. And then we're going to look at some grafting technique, or some bone graft theory, some grafting techniques, and management of segmental bone loss, management of contained bony defects. And really what we do from a fracture management perspective is applying cellular biology and applying the basic sciences around fracture healing. So we really have to have a good understanding of that and how what we do affects that. I think we really do need to understand the components of that cellular biology. All of you should be familiar with or becoming familiar with osteoclasts and the other cells within the bony matrix, osteoclast being the most frequently occurring cell in the matrix. It's a multinucleate cell, monocyte, macrophage lineage. Only calcitonin can directly influence osteoclastic activity. Obviously, as I'm sure most of you are aware, the activity is moderated by the Rankel pathway, which is very much integral to the bone cycle and the way that osteoblasts and osteoclasts interact. Here we have an osteoclast in its Hauschup's lacunae with its ruffle membrane, a diagrammatic version of that. All of you who are heading for the exam should be able to draw a very 5-second osteoclast and how it interacts with bone. And then obviously we have a cutting cone here and its components. Again, if you can draw a 5-second cutting cone, and you can start to explain how primary bone healing starts to work and understand that basic science and get it across to your examiner, you shouldn't have much problem passing the exam. Osteoblasts come from a different cell line. They're mesenchymal stromal stem cells, and their main function is obviously to manufacture osteoid. And to do that, they've got the structural capability within the intracellular matrix to achieve that, really prolific mitochondria, Golgi, rough endoplasmic reticulum. They have high alkaline phosphatase levels, and hence why you get, excuse the spelling, high alk phos levels with certain metabolic bone issues. After a period of activity, osteoblasts can go one of three ways. They apoptose and undergo programmed cell death and are no longer, or they become bone lining cells, or they become osteocytes. Bone lining cells sit on the surface of bone. With an increase in parathyroid hormone, it's been shown that these cells change their configuration, exposing the underlying bone to osteoclasts and allow the remodeling process to start. Some bone lining cells can then undergo reactivation, turn back into osteoblasts. Osteocytes, 90% of the cellular component of the bone, they're essentially osteoblasts that have got stuck in the extracellular matrix. They function to regulate calcium metabolism. As I'm sure all of you hate drawing those pictures, but again, if you can do a simple calcium metabolism picture, it may get you through a basic science viva. They respond to micromechanical and endocrine stimuli inhibited by parathyroid hormone, stimulated by calcitonin. They're joined together by canaliculi, which allows them to communicate with the neighboring cells and respond to the pressures that are upon them, allowing the bone to change. Should understand the Rankel soap opera and how osteoblasts and osteoclasts interact, and the integral parts of that. So how osteoblasts receive messages from the osteocyte, essentially exciting them to produce Rankel, which then goes and binds to the rank on osteoclasts, stimulating them and almost to a certain extent kickstarting the bone cycle. And that's obviously set off to a degree by all sorts of hormones, including calcitonin, OPG, osteoprotegrin, blocks the Rankel and stops it from binding the rank, therefore reducing the stimulation of local osteoclasts and controlling the bone cycle. Bone healing, you'll all be familiar with pictures like this. Hematoma formation of the fibrocartilaginous callus, that hardening of the callus with laying down of osteoid, and bone remodeling. Obviously, it's not quite as simple as that, and that's what we're going to look at over the course of the next few slides. Stage of the fracture healing, again, it's another diagrammatic representation of it, another schematic of it, which is essentially split into a cellular stage, a vascular stage, the formation of primary callus, formation of a stiffer callus, and that callus then maturing, consolidating and remodeling. When we think of bone healing, everyone should be familiar with the concept of relative stability and fractures potentially healing the callus, and absolute stability, where you wouldn't necessarily expect to see callus due to the nature of the biology that's underpinning this, to heal the fracture. Relative stability results in enchondral ossification, callus formation. Absolute stability is essentially primary bone healing or contact healing with no callus, and it uses the cutting cone. Some other basic science that all perhaps should be familiar with: in the mid-1800s, Wolff recognized from histological samples really that there was the trabecular pattern of bone, in particular the proximal femur, and he described what he felt were potentially tension and compression forces which resulted in the bone forming in the way that it did. So that's one theory that we should all be aware of, or law I should say, and certainly that rings true today. We certainly do see that bone responds to the stress that's upon it, and it remodels along those lines of stress, and we've got some examples we could touch on later looking at that. The classic, though, is obviously parent strain theory, that the granulation tissue that forms at the broken ends of bone initially has 100% strain upon it. Then as the cartilage matrix is laid down in the enchondral ossification situation, it stiffens to an extent that then the cell lineage change from a fibroblastic from fibroblasts to osteoblasts from the mesenchymal stem cells, to allow the osteoblasts to then produce osteoid new bone, stiffening the fracture and allowing the later process of cutting cones to form, remodeling, consolidating that fracture. Frost came with his mechanostat idea, which is essentially a theory which some people say helps to explain Wolff's law to a certain extent, but really what it revolves around is the formation and resorption of bone related to the local elastic deformation of bone. And if that's within a physiological level, you get bone healing. If it's not, then if it's overloaded, you don't get bone healing. If it's particularly high levels of deformation in the area, it becomes pathological. What Frost did end with was essentially saying that bone adapts to according to its everyday usage, and we're well aware of that from disuse osteopenia and osteoporosis in the elderly who have low activity. All these theories were brought under one hat a few years back in an article in a Bone and Joint journal. Many notable orthopedic surgeons from this country, under the title of the bone healing and non-union theory, which essentially says that bone healing and non-union revolves around strain, and too much strain is a bad thing, clearly. They describe the bone healing unit. They describe strain, which is obviously the change in length according to load, and they describe strain tolerance, which is in essence what Perrin touched on in terms of the relative strain that certain tissue types are capable of withstanding. In terms of the bone healing unit, they say that they gave this statement, which essentially means that to allow the fracture to heal, it has to be able to respond to the strain around it and lessen the strain so bone can form. A graphical representation of that. So A isn't really relevant when you're on Earth, certainly, unless you're in bed for a particularly long period of time. Hopefully most of us are in the green zone, or we keep most of our patients in the green zone, allowing fracture healing to happen. But if strain gets too high at point C, when it crosses under the graph, obviously fractures won't heal, and that's when we're heading towards non-unions and problems for patients, problems for surgeons. So in essence, a non-union is a failure of the bone healing unit to get on top of that strain, and it's either then hypertrophic, atrophic, or infective. Popular picture from the AO. Hypertrophic non-unions look either like an elephant's foot or a horse hoof. Atrophic just don't look like there's much going on at all. Necrotic, you will see dead pieces of bone clearly. And then on the avascular side, if there's a defect, it's not going to heal. And we'll talk about some factors that you need to achieve when you're thinking about fracture fixation, which should hopefully avoid defect. So what you're trying to avoid, you're trying to manage open fractures appropriately. You're trying to recognize patient characteristics. You're trying to recognize fracture characteristics. You're trying to plan. You're trying to think about which strategy you're going to use to fix your fracture. What fracture pattern is it? How do you need to modify your techniques to allow you to do that? How are you going to approach the fracture most appropriately, with avoiding too much periosteal stripping? You need to make sure your fixation techers is on top form as well, and that you're using your equipment appropriately. So we're going to move on to the principles of fracture fixation. Ramina, I don't know if there's been any questions, burning desires that anyone wants to ask just now.
No questions just yet, but I'll keep an eye on it and let you know.
Perfect. So principles of fracture fixation. So sort of classic AO teaching, you're looking for what's your aim? You're looking for anatomical articular reduction and essentially absolute stability if you've got an intra-articular element to your fracture. You're looking to try and restore length, alignment and function, and try and allow early motion to the joints, and early movement and early weight bearing if possible, and stimulation. We try and think of that in our unit as these sort of 5 pillars. So you're looking for contact, alignment, biology. So you're looking to not take biology out of the fracture as much as you can. You're trying to avoid stripping. You're trying to avoid, you're trying to use techniques which try and keep biology in the fracture. You're trying to avoid infection by treating open fractures as you might, as I feel and as we feel you should. And you're looking for a fracture fixation method which gives you stability, which allows the patient then to stimulate the fracture by loading the fracture, applying some of the theories that we've looked at in the previous section. So this gentleman on the right is Durai Nayagam. So he's one of the doyens of modern orthopedics in this country to a certain extent, or to a greater extent. And he sort of runs by the theory of the law of the instrument. So if all you have is a hammer, everything's going to look like a nail. So his standpoint is that really, as trauma surgeons, as trauma orthopedic surgeons, we should be in a position where we can apply our technique to our fracture, and skill shouldn't necessarily, and ability shouldn't necessarily hamper that treatment. So not everything's a nail, not everything's a plate, not everything's a frame. So, you know, often in a trauma meeting, you'll stick a fracture up and platers will say, well, I'll plate that with a medial plate on the distal tibia, which is obviously heresy in Liverpool, or I'm going to bash a nail down that, and then the frames. But actually, you've got to make sure that you're taking into account the fracture characteristics and the patient characteristics, which mean you're going to hopefully get a successful result in the end. So back to that slide we talked about, we've got to think about the methods that we're going to use. Are we going to go with relative stability, or are we able to get absolute stability? Obviously, fracture pattern determines that. So if it's a transverse fracture or an oblique fracture, it certainly lends itself to an absolute stability pathway. If it's more comminuted, then you may be looking at a relative stability. If it's periarticular fracture, you could go with extension into the metathesis, you may be able to look at both forms to a certain extent. Some simple techniques you need to obviously be aware of. So lag screw techniques, whether that be with a cancella screw or with a cortical screw. We'll look at those techniques now. So for a partially threaded cancella screw, and I have to say for periarticular fractures, I tend not to use these. And equally, I tend not to use cannulated screws. I don't really like them. I don't think they're quite as strong as a good, for want of a better word, cortical lag screw. So you take your, this would be for a large fragment canceller screw, you take your 3.2mm drill. Don't make sure you don't go through the far cortex. Then obviously it's reliant very much on anatomical reduction, and then you insert your screw. I do use a lot of washers around periarticular fractures to try and spread the load and make sure that we don't lose screw heads, and to increase our ability to get compression between those fragments. A cortical lag screw, the classic method of teaching is that you go with the larger drill. So if that be with a small frag, you'd go with the 3.5 drill first, 90 degrees to the fracture site, with obviously with an anatomical reduction. Then you put your witch's hat or your drill guide in and drill with the 2.5mm drill, with the plan that having tapped the near cortex, that the screw will engage the far cortex, giving you compression across the fracture site. Again, those going for the exam, you need to be able to explain that and be able to draw the theory. And you probably should know a little bit about this. This is your this is a table essentially showing the different sizes of drills commonly used on small fragment, large fragment sets. So they may ask you to explain how you do a lag screw in a large frag set, or so just make sure that you're aware of that, or with a mini fragment set, so with, let's say, a 2.7 or for a 2.7 mil screw, sorry, and which drills you're going to use, just to try and make you think a little bit outside the box. An example of that, so this chap had a segmental tibial fracture, actually, that's which was open distally. For mine, that's going to be a frame. He had this intra-articular involvement with his tibial plateau, extension down into his metaphysis, clearly a high energy injury. So in this situation, have a good look at the CT scan, work out from the axials where the plane of the fracture is, for want of a better word. I then usually minimally invasively, didn't think really there was much in the way of compression, or much in the way of much to be gained from trying to move this piece, so just ignored that to a certain extent. But percutaneously, a big periarticular bone clamp to pull everything back together again. And then 3 lag screws was essentially a fracture in the coronal plane. 3 lag screws to pull everything together. I thought we had a pretty good articular reduction, was quite happy with that. And then you can see that this is the talar spatial frame actually for this guy, because it was segmental. And because it was a couple of weeks down the track, it was going to be a little less easy to reduce acutely as the Whittle and Lizeroff. So I went with a double stack TSF, which was quite entertaining for the Smith and Nephew rep, but there we are. Compression plating. These are pictures that most of you will probably be aware of. Obviously, you have on one side of the fracture, you would drill a concentric screw, and then this is the eccentric screw going in to allow the plates and allow the screw going into the plate to move the bone relative to the plate. I hope that makes sense. In the diagrammatic form, you have the eccentric screw here, the concentric screw that's already tightened down, and as the screw tightens in, compression across the fracture site. Pre-bending the plates obviously very important, so you don't open up on the tension side, so you get the fracture coming together very nicely. There are other ways of using compression plating by creating an axilla between the plate and the bone. Here we are, anatomical reduction, concentric screw, and you want to pull the bone on the left to the fracture on the right, the axilla having been created in this zone here. If you tried to do it the other way around, you'd end up pushing the bone that way and you would lose your anatomic reduction. An example of that is not really the best, but we did get some compression across this fracture. He had a femoral shaft as well. It was open over as an olecranon, and the plastic surgeon taught me some jiggery-pokery about how he might cover that. This is another way of getting compression, perhaps used less frequently in acute fractures, although perhaps if you're struggling to get length on a fibula, which you're bridging, you might put a screw out with the plate and then use a push-pull technique. But this is the articulated compression device, so fixed distally, it slots into a hole on the plate and then a screw out with the plate, allowing you to ratchet up compression across the fracture site by closing down the space between the plate and the screw. You can get more compression by adding this screw in the eccentric hole, achieving more compression and more stability, and certainly hopefully achieving more in the way of getting your cutting cones going. So we use this a lot for non-union fractures. tension band theories, changing tension forces into compressive forces, typically used around the olecranon, around the medial malleolus, but it's actually more frequent, more widely used than you think. It's actually DHSs, and even some compression platings are based around tension bands to a certain extent. It's actually quite a good way of thinking of the reverse rule of thumbs when it comes to blocking screws and deformity correction. We won't touch on that today, but that's perhaps a time for another talk. But just have a think about that when you're bending rulers, etc. So yeah, so tension bands, changing tension forces into compression forces. And I'm sure, well, in the UK, obviously, I think we had to do 10 tension bands of olecranons when we were training, just to make sure we could see CT. Touching on a tension band to a degree, I suppose, and the articulated compression device. This is a chap treated something elsewhere with a quite challenging proximal femoral fracture. They got a really nice reduction. They put a PFNA down. You'll notice that unfortunately they put one locking screw and they didn't put it in the dynamic part of the hole. And so he came back to us, and we could see just it's starting to bend a little bit as the fractures collapsed above. And it goes to break. And at this stage, he had quite a lot of pain, and CT suggested the fracture wasn't united. And it almost certainly would have gone to probably some form of hypertrophic non-union if we hadn't got involved. So we use this fairly old school implant, which we use quite frequently for proximal femoral non-unions, which is a blade plate. Crucial thing is to follow the instructions, basically, get the blade in nicely, and get this cancella screw, this big 6.5mm screw in as well before you use the compression device. You can see where the articulated compression device has been. It's had its one arm in that hole and its other arm screwed into the bone here. Good amount of compression across. If you haven't got this extra cancella screw in, you do run the risk of pulling the blade out, and then obviously it's filled. You might say that's particularly stiff, but we were going for the stiffest construct we could produce. Interestingly, he's got, he's got some heterotrophic bone on the outside of the plate, but he went on to heal and he's asymptomatic, and was hoping to go to Cyprus pre-lockdown, but that got scuppered. Moving on to relatively stable constructs, and this chap, high energy injury, came off his motorbike, or got knocked off his motorbike, should I say, a floating knee. Intra-articular extension, distal femur, quite a comminuted, distal tibia, sorry, quite a comminuted fracture. Some translation, given the appearances of his fibula, translation and shortening. High energy injury, had actually lost his heel pad, which after we'd done our bits, my colleague Dave Bell, very talented plastic surgeon, managed to do medial plantar rotational local flap, which has reconstructed his heel really nicely, and he's back to pretty good function. This is what we did. We did the femur first, naturally, retrogrades. So that's my go-to for these. It works really well. You can get your alignment sorted out. It's quite easy to achieve length, and it doesn't take too much to actually just pull on the leg, get it reduced over a from triangle. The tibia was challenging, to say the least. It was closed, but it was high energy and he was quite swollen. With the guide wire down, I haven't got the pictures of the II, unfortunately, but with the guide wire down, it was quite clear he was going to be translated and valgus if we didn't fix the fibula. So we chose to fix the fibula. We've gone with a lag screw cross and oblique fracture with the neutralization plate, obviously here. We had already fixed with two periarticular lag screws. The distal tibia, again, I don't like cannulated screws. These are fully threaded screws with washers. Then the nail went down. You can just about see, and you can certainly see on there, little bit of a hole where we did pop a blocking screw down just to help us a little bit. Well, blocking wire, I should say. I tend to go with wires first and then replace with screws. And that seems to have given us decent alignment. It's healed with callus, it's relatively stable. And it's both fractures have healed with callus, it's relatively stable construct. So the fibula hasn't, that's healed with cutting cones, and that's actually quite a nice demonstration of the two methods of bone healing next to one another, isn't it? Bridge plating. So looking at this guy, polytrauma again, had a horrendous humeral fracture which has been left to heal in a cast, and it's actually done remarkably well. He had a bit of a head injury which may have helped him from that perspective. You can see the orientation of the proximal tibial fracture in terms of its periarticular component from the axial view here, which is what I was referring to earlier on with the segmental one. Some comminution, it was closed, but again, very swollen. He has a history of alcoholism, and I wasn't convinced that he would be a great one for a frame. So we decided to do an X-fix assist or femoral distractor assisted bridge plating. So you can see the distractor goes on. We get length alignment on both in both the coronal and sagittal planes to allow us to then slide the plates minimally invasively down the lateral border of the tibia. Oops, sorry, excuse me, getting a bit excited. Again, 2 lag screws with washers, one slightly long maybe, and then the plate goes on. Quite happy with the way things are looking in terms of alignment there. And then a few months down the line now, a couple of things to note. So we've gone, when we go with these long plates, whether it be femur, tibia, we go with near, far, far principle. So we essentially treat it like an internal X-fix, if that makes sense. So near, far, it's very difficult to go near, far, far, obviously, when it's metaphyseal like this and periarticular. It is, however, healing with callus, and you can see that both on the AP view here, medially, and posteriorly on the lateral view. The alignment here is actually pretty good. I was quite happy with his articular surface on both the AP and the lateral views. He's just a slight bit flexed on this view, so that's why we're just seeing a funny view of this articular surface, but he's actually functioning pretty well. When I was going to our elective unit during lockdown, his rehab centre is just across the road, and I saw him walking across the road with the physios, and he was full of the joys. So this is one from last week, an interesting technique, which one of my colleagues, one of my senior colleagues, respect very highly. He's had a massive influence on my career and was very keen to show me and try. And that's this gentleman, Badri Narayan. So transverse humeral fractures in healthy patients in Brazil, or the Brazilian team have written up a series of minimally invasive platings of humeral fractures, and this is something that's done quite a lot by Badri's colleagues and friends in India. And so here we go. Look, X-rays may look a bit wacky to some of you, but it's perhaps no different to a very short humeral nail in the right patient. And it is all about patient selection after all. And this, I'm assured, will heal with callus, but watch this space. It was an interesting one because he was quite a big muscular tree surgeon, but we got it in there, and I think he'll be good. He's going to have his back fixed, having fallen off a tree because his harness broke. So this is looking at some of the other techniques, which relatively stable techniques in theory, which heal with callus. This young man is a delivery rider, and he got attacked for his money just in the midst of lockdown, I think, ironically. And he has this distal tibial fracture. It's oblique in nature, and I think anything which is oblique like this and in the distal diaphysis heading into metastasis, you should have a really very high threshold for looking at the posterior malleolus. I think there's a few papers out there that suggest these type of fractures involved with posterior fractures about 80% of the times, but actually looking at other papers, if you do an MR or a CT, you'll almost certainly find some sort of involvement. But if you look very closely with this one, there's quite significant posterior mal involvement, which was missed actually. unfortunately, and he was initially managed conservatively, but fortunately one of my colleagues, one of my limb recon colleagues, saw him in fracture clinic, and we got on top of him quite quickly after that. So quite a significant displacement. There's all sorts of classifications for posterior malleolus fractures out there now. There's one from our unit. All I need to know is it needs fixing. His fibula is quite short here. I don't know if you can appreciate that. So his fibula is pretty bad as well. So we felt we had to tackle both. This was at about 6 weeks. So not really one to nail, and probably not really one to nail even if it were fresh. I think you'd struggle to get that back with AP screws. This is something you're gonna have to tackle from the back all day, every day, I think. Again, some 3D rendered images just to show you the extent of the posterior malleolus involvement and the displacement of the fibula, things that we thought we needed to get on top of. So we use EVOS in our unit, which is a great system. I shouldn't really say that out loud. I'm not advertising Smith & Nephew products, but it's actually a really good system. The fibulas, we've managed the posterior malleolus with, the tibia we've managed the posterior malleolus with a nice 2.7 plate. These are actually lag screws again. We're going back to that principle of trying to get absolute stability of periarticular fractures. The plate was actually put on in buttress mode to start with though, so we've buttressed up using this screw here and then lagged through the plate here. The fibula we've bridged across. By the time we'd actually taken it down and moved it and got it reduced with the posterior malleolus, this was a bit mushy, so we've bridged across there. So again, you're not going to expect that to heal with callus. How did we tackle the tibia? Well, we've gone with a TSF, talar spatial frame, particularly useful in this situation, heading out towards 6 weeks. There will be some efforts of healing despite what you see here, and to try and pull a non-union apart with and Lizros actually quite challenging. Talar spatial frame is really quite powerful. However, some points of interest with the talar spatial frame. It's a half pin favourable frame because you've got to put the struts in certain places. If you put lots of wires in, sometimes you struggle. And we set the rings off coronal plane wires, which you can see on this view here. I think I think we ended up with a coronal plane and a medial face wire here, possibly with a transfibular wire even. I think we managed to get that through the plate, and with a half pin or two down at the bottom end, and ran the program. And he's reduced quite nicely, and you can see relative stability. He's healing with callus. The struts come out. The struts do wobble a bit, and the patients don't like that so much. So we swap the struts out for the threaded rods. We either just drop a couple of threaded rods in, or we take all the struts out and drop threaded rods in. And I think that touches on something that we'll come to in the next few slides about changing the environment of the fracture as well. At that stage, when you start to see callus formation. And that's where we're heading now. So this lady, she was driving a Nissan Micra or something similar, was hit by some guys who were in a stolen Golf GTI or some such. Quite a lot of intrusion into her side of the car, significant energy into the fracture, as you can see. She's actually got a bit of medial cortex here that's been driven into a distal tibial metathesis. And it's acting like a log splitter essentially, and split the distal femur in two. You can see that quite nicely on these images. Again, 3D rendered images showing the articular flow, which is obviously crucial. So how to manage that? So we actually managed. We went retro. I tend to go retrograde, as I say with these. We had to pull that medial cortex out. It is essentially a segmental fracture, for want of a better description. It went on to this, so part of it healed and part of it didn't. So she had quite a lot of symptoms around the top end here, and you can see how things have started to dynamize, and she started to bend screws, and she was quite significantly just impaired by this, really, for want of a better word. You can see there's obviously been some wobble here. The nail's starting to loosen off a little bit. So we went with we employed something called reverse dynamization here. So we gave it all a really good freshen up. And you can see we've taken an osteotome all around here just to patell the fracture, lift the periosteum up, lift the cortex up just to refresh everything. And we've gone with a large fragment plate just to change the strain environment at this top end. So we're using some of those theories we talked about earlier, the BHN theories. Strain was obviously too much in that area to heal the fracture, so we've changed strain environment, gone from a very high strain environment to a very low strain environment. The strain's changed in this fracture as it's healed because this part of the segment has healed, and this then became a very high strain environment. So we felt we needed to do something to take that away. And she's gone on to heal very nicely. And this sort of comes to a theory that's been, it's not new. My senior colleague, Mr. Nigam, recalls frequently having to retension or reinsert wires into Lizaroff frames to, once callus starts to form, to try and stiffen callus. And Veda Glatt has done a lot of work recently in laboratory models. I think she's based somewhere in the States. I'm not 100% sure where. They've demonstrated really once they go with quite a construct with low axial stiffness, and then they go to they drop extra pins, or they connect extra pins into the external fixators that they have on their animal models, and demonstrate that the fracture healing time is quite significantly reduced. And I think that example we've just looked at is an example of that. There are other times when we've used it. We put ghost pins into tailor spatial frames, for example, which aren't necessarily connected to the frame, and then we connect them when we start to see callus form. And we've seen in a couple of cases that that's really has quite profound effects. So that's the end of that bit. Hoping that all makes sense. Ruminaries, anyone got any burning desires?
Yeah, quite a few questions for that talk. The first one is, with regards to tibial plateau fractures, the raft screws, does it matter if they're through the plate or outside?
No, not at all, actually. So some of the manufacturers' plates, so Stryker, for example, their plates, although they're sold as anatomic, aren't desperately anatomic. So you find that you struggle to get it exactly where you want to. So that engenders that you have to go outside the plate. You've got to remember that the fracture, especially in the split depression or anything that's Schatzker 2 through 3, once the patient starts to weight bear, the bone is going to end up going back wherever it wants to go, despite whatever you might fill the defect with. And it's all reliant very much on the quality of your raft screw. So you don't want to get that. You want to get that really into the nice subchondral bone and almost as high as you possibly can within reason. So you don't want it to be intra-articular. So sometimes it may be in the plate, it may not be. I mentioned EVOS before. They do a really nice partial articular plate, which comes really quite nice and tight up. I haven't got a picture of that. We maybe could go to one later on if people are desperately keen to see that. Can log on to the X-ray system and show how that works. But you can get that really nicely. It's just, it'll depend on the patient. It'll depend on the fracture. You just have to have that plan in your mind and sort of plan A, plan B, and work out how you're going to do it. Okay.
The other question was just to clarify the screw regarding the distal, the blade plate for the proximal femoral non-union. Yeah. Was the screw that was distal to the blade plate? What was the purpose of that screw?
So we'll go back to the description of the. So it's just that screw there. So yeah. You imagine the articulated compression device. Should know my slide number, shouldn't I? I should be able to jump between the slides.
Distal to the plate, yeah.
So there you go. So that was distal femur, the schematic that from the AO there. But so if you just flip it upside down, your articulated device would go here with the ratchet there, with the screw hole in the articulated device in this screw here, with the arm of the screw in this part of the plate. You ratchet it, and then you start putting the other screws into the plate. And I leave that screw just so there's no There's no chance of fracture through the screw hole. You don't have to leave the screw in there, but that's how the articulated device, the compression device works. You have to attach it to the bone, it hooks onto the plate, and then it pulls the plate down, essentially pulling the compression, giving you compression across this area.
Okay, I think the last question, which is actually quite pertinent, it's a common exam question with regards to ipsilateral tibial and femoral fractures. Which one to fix first, and how? And the same with ipsilateral neck and shaft femoral fractures.
We've got a neck and shaft femoral fracture coming in a minute.
Okay.
We'll cross that bridge when we come to it. So tibia and femur, I go femur first. I go over a from. There are other ways you can do it. There's a Russell frame, which is quite nice. You could put it on a Russell frame, then flick it around, and then do the tibia. But I would always start with the femur and then work to the tibia. I wouldn't necessarily put an X-fix on. I wouldn't necessarily keep it in a plaster. I would just be gentle, basically. You could even put, what I sometimes do, or I have done in the past, is put one from under the femur, one from under the tibia, so your assistant is not moving the tibia around too much. You can do retrograde femurs with the tibia in an X-fix, but you just have to think where you're putting your X-fix pins and how high you're coming with your X-fix on your tibia, so you can still get your retrograde entry point. Almost impossible to do these antegrade, so then that slightly may change your tack to a certain extent, but I'd still probably go femur first. And you could do the femur freehand antegrade if you were concerned about putting it on the traction table.
Okay, thank you.
Happy for everyone happy for us to move on?
Yeah, we can move on.
Perfect. So last but not least, bone grafting and managing defects, and this is really where we make our money. Decision making, and exactly how we're going to manage these things. So bone grafting, I think it's probably just worth spending a bit of time on this slide. It's busy, but this is all you're going to get asked, I would have thought, about basic sciences of bone grafting. What you're trying to achieve? Are you trying to achieve structural stability? Are you trying to stimulate bone formation, or are you trying to enhance bone healing? So if you've got a non-union, you're going to try and wake things up again with your osteotome, and then put some bone graft in. And what are the properties of your bone graft? Are they osteogenic? Does it contain living cells? Is it osteoconductive? Has it got a three-dimensional scaffold that's going to allow ingrowth and on-growth of those as fracture healing and the non-union starts to develop? Or is it osteoinductive? Does it provide some sort of biological stimulus? And invariably, well, autograft certainly is both conductive and inductive. It does contain living cells if it's by nature, so it's all three of those. So it's just worth having a quick idea of that. And if you start dropping those words into your Viva answer, then the person sat opposite you is going to start giving you points, because you quite clearly might have an idea what you're talking about. Allografts, they can be anatomical, so you can get chunks of proximal femur if you want to stick into people. And I personally use a lot of fresh frozen allografts in big defects around tibial plateaus. I think that's the way forward. If sometimes I might actually use autograft in that situation, take a nice, even in an acute fracture, take a nice tricortical graft and put that in underneath the condyle to lift things up. They're sterile. They come in various forms, whether that be powdered gels, paste, chips, strips, whatever that might be. Autograft, so in certain situations when you're managing defects, you will go with a vascularized fibula, for example. So you can get vascularized grafts. They have certain properties and certain benefits in certain scenarios. Clearly, there's donor site morbidity, and Synthes will have us believe there's significant donor site morbidity from iliac crest bone graft versus their rear. I'm not quite sure that's true. You get slightly different quality bone graft when you use an iliac crest bone graft, especially if you use posterior iliac spine, you get a really nice graft from back there, and you can actually get quite big volumes. Bone graft substitutes, we're not really going to touch on that because it's not really, and void fillers, we're not really touch on that because it's not an infection talk, and it's not, so we use a lot of calcium sulfate. I don't like Cerament because of the inorganic component to it. We use Stimulan, which absorbs rapidly, really, and it gives us the ability to put pretty much whatever antibiotic we can in. It's only really just become licensed for that purpose. Calcium phosphate I've very rarely used, and ceramics like Bioglass are actually quite good again in terms of management of osteomyelitis, but that's for another talk. I think at this stage we should talk about open fractures because that's usually how we end up with defects, certainly in our unit. So everyone will be aware of the BOASTs. There's been, which is produced by the BOA, BAPRAS, BLRS and the OTS. And that really revolves around the management of long bone fractures, hindfoot fractures, midfoot fractures. Work in a major trauma centre, and we're trying to get our orthoplastics system well and truly set up. It's sort of in its infancy, to say the least, at the moment, but we're getting there. The most recent document, which is hot off the press from the end of August, is the standards for the management of open fractures. Some notable authors there. It really is actually a very good read. Even if you're not interested in the management of open fractures, if you're heading towards your exam, have a good look at that, because there's quite a few technical tips, not just on how to manage, that aren't just applicable to the management of open fractures, but so many other aspects of fracture management, or complex fracture management, certainly. I think it would be remiss of us to mention this paper and some of the work that's been going on in North Bristol. Personally, 3B fractures with devitalized cortical segments. The devitalized cortical segments go in the bin, they don't go back in the tibia. I think that's it's dangerous from my perspective. They have great success. I think they have great success because of the aggressiveness of their debridement means that they end up going to a lot of free flaps, so that might be one reason. But certainly it's not the way I would choose to have my open tibia managed, but they do some very good work down there. Here we go. So a couple of cases just to sort of think about grafting techniques. This young man was knocked off his bike, open fracture, 3B, big soft tissue component, compartment syndrome, opened on on hour 0 pretty much. Needed a free flap, couldn't have an ALT from one side, so they had to open up his thigh the other. He had the devitalized fragments were taken out of him, concomitant medial malleolus, contained defect. Alignment actually pretty good in his TSF, although those x-rays aren't necessarily that convincing. And here we go. So we went with a rear for him. It's quite good for contained defects, and I don't think he would necessarily have tolerated us bashing the hell out of his iliac crest, and I don't think he'd have enjoyed the pain. This is the old rear, so rear 1. We've gone to rear 2 now, which is actually a really quite neat system. You get your graft, dry it out, and then stick it in the hole essentially, so you can see this cloudiness here. We did reorientate his fracture a little bit, sorry, just to get the alignment a little bit better and get some compression, and you can see he's gone on to heal quite nicely with callus. He's starting to remodel, so it maybe wasn't quite right in the sagittal plane. You can see that he's almost certainly starting to remodel here by the way the callus is. He's a young man, so he's got some remodeling potential certainly, and you can see his bones responding to the biomechanical stimulus around about it, and is behaving as Wolff suggested it might. And so another horrendous tibial fracture. He actually had a ipsilateral femoral shaft and neck fracture, so it wasn't my case. I won't show those x-rays, but we have got one coming, so don't get too carried away about that. Wasn't debrided by me. I'm told all these fragments were passed the tug test. Whether that's true or not, hard to believe. But anyway, so he went and had his soft tissue cover. Unfortunately, I think I may have been on leave when my plastics colleagues covered him. So at that stage, I really only had one option, which was to go with Lizaroff. I felt open fractures don't, when obviously within the 72 hours, if you can do fix and flap, then that's fine. But in this situation, we were well beyond that 72 hours, and I'm not sure you could have nailed that anyway. So we've gone to Lizaroff, and this is, so I think the frame went on March, and this is last November, December. Not much in the way of healing. Some little bits have started to heal maybe, but not convincing, and he's still in a bit of pain. Again, an interesting host. So we've gone with this. This is actually a central bone grafting technique. So we took Rhea from him, and we took, I think we took at least one iliac crest. We may have taken both. We fixed his fibula. He'd already had 10 months in a frame, so I didn't think there was any point in rejigging his frame, and he was already starting to complain about it. Central bone grafting, you essentially denude the, well, you don't denude, you patella the fibula, patella the tibia, you plate, bridge plate techniques across the tibia. Because his fibula was broken, we had to fix that to give us our strut, and then lay bone graft on the interosseous membrane to try and make the leg one, essentially, to try and manage the segmental bone loss, although it wasn't really segmental bone loss, but try and manage the defect. His fibula's maybe a bit short, but I suspect that won't probably cause him much problem, given the fact that we've stiffened the syndesmosis at this stage in the way that we have. So saw him last week, actually. So he's gone to this situation where he's now got graft, which is integrated very nicely. And is now essentially given him a one bone leg. He's walking without aid, and has got a pretty good range of movement in his ankle, and his gait's essentially normal. I'm quite happy with the result, and I think he is too. Open femur this time with a floating knee, high energy motorcycle accident. You can see that this is just going to be crazy bone loss. But eagle-eyed amongst you would recognise that he's lost his patella previously from a patellectomy, but for patellofemoral joint issues. He's essentially dusted his distal femoral metathesis, as demonstrated here. I've saved you the intraoperative pictures. I've spared you the intraoperative pictures. This is just Polacost cement. We brought the condyles back together again with a series of lag screws, lateral plate, striker, not my favourite, but it's worked in this situation. This is a lateral tibial plate turned upside down, to give us some decent hold and to stop any collapse into varus. And then we've here fixed the tibial fracture. This wasn't, we went on a busman's holiday to do this during lockdown, so we're not fixed in our unit, not with our kit. So some of the screws are a bit long, and when we asked for a particular plate we wanted to put on this side, they didn't have it, so we bailed. He subsequently had his masculate finished, for want of a better word. So we've opened up the membrane, and we've grafted into that. So that was rear iliac crest and some bone chips. Timings of that. So this was about heading towards 8 weeks following the primary surgery, our first operation on him. Which is perhaps just pushing the boundaries a little bit. For those of you aware, masculate, you could essentially put anything in the hole as long as it's sterile. It will form the body will form a membrane around about it, which then you can open up, which is highly vascular, and put your bone graft in there. Reserve that for femurs. I don't desperately like treating bone defects in tibias this way, and we'll talk about that in a minute. And hopefully it'll work in him. The issue being, when you go into the tibias, and Pallister's written quite a nice paper on this, looking at a series, I think it was about 15 or 20 cases, that the gravity effect in the tibia seems to have much more of an effect. So as soon as your patient stands, the graft tends to drift to the bottom of the defect. There are things that are coming onto the market now to try and guard against that, sort of graft cages and the 4-web stuff that some people have seen. Nima Hadari's been in the Daily Mail with a case that he's done. Alex Trumpeter's done a few as well, I know. Quite often after failed ankle replacements, when there's been significant bone loss, or infected ankle replacements when at debridement there's been significant bone loss, they seem to work well. There's been no negative press about them as yet, but brave surgery. Anyway, so that's masculae. So we can, I'm sure there'll be some questions about that. We can come back to that one. And this is segmental defect in the tibia. So again, high energy injury. He's essentially got a floating knee. He had a femur above this, which was fixed first. You can see, not my initial debridement. This was the pictures on the right hand side after multiple visits to the theatre, when I eventually got a hold of him, for want of a better word. The cannulated screws placed by my colleague. A lot of devitalized bone. I think if you try and put those bits back in and plate them, or unicortical plates, and then try and nail, that would end up in an absolute disaster. But there by the grace of God. So how are we going to manage him? So we're going to look at bone transport. We're going to pop him into an Alizaroff frame. This is essentially the standard transport frame. So you've got a ring up by the knee, which is got 4 wires on it. There's a spread of wires, coronal plane. We can talk about the techniques of that if people want to, but it's probably a bit too much for this arena, unless people are desperate to know about that. We can talk about it. You can see it on here. So we set on a coronal plane wire, good spread of the wires across to stop the tibia becoming extended when the osteotomy happens. We did the osteotomy at the same time as application of frame here. There's been a little propagation of the osteotomy at the back, and perhaps could have squidged it up a bit more, but it actually looks pretty good. He's got quite a big defect to fill. My alignment looks pretty good. Of course, quite chuffed when we saw those x-rays. So he goes on and does his transport, and he actually needed to get some length as well. I think he actually did about 8 centimeters in the end, and you can see he's got some really good regenerate. And this is sort of, I think this was about 5 months out. He's docked quite nicely. We go in and do docking site procedures, and that's why these 2 rings are a little bit further apart than some might expect, because you need the space to get your hands in to do the docking site. Really very distal here as well. When we do the docking site, we go in and do what we did with one of the previous cases, go and patella the bone ends as much as we can, compress it as much as we can. And in this situation, we use Inductos, which is BMP3. So another bone graft substitute, for want of a better word, or osteoinductive tool in our armory, and it does seem to work very well, and you do get a lot of good positive response from that. So this is what he looks like, and I think he, in the coronal plane, looks pretty good. Quite happy with that. It's very sclerotic in the middle there, but it's almost certainly healed. He's walking around. It's actually got pretty good range of movement. He's driving, and he's back to quite a manual job. Initially, I think we had pretty good contact, but it was quite a small piece coming down to a larger piece. It was a bit off at the front, but I think he's actually remodeling and demonstrating Wolff's laws. So this is probably what some people have been waiting to see. So this is the femoral shaft fracture. There's 10% chance that he's going to have a femoral neck fracture associated with this, and needless to say, there you go. So this looks highly comminuted, again, high energy. He's a motorcyclist hit by a white van. No tibial fracture in this situation, thank God. He goes to theatre. bone loss at the time. I thought we'd shortened him probably about 4 centimeters, but decided we need to shorten him to contact, blocking screws to get our alignment. This is post retrograde nail, and this is the way I do them. Not that I've done many, but I go retrograde nail first for the femoral shaft fracture, because that gives you something to pull on to help you reduce your femoral neck fracture. And in this situation, that definitely was the case. Fortunately, it came back closed, so it didn't need to open. And thank God, because I don't know what his Powell's angle is here, but I think it's gone well beyond any Powell's classification. And this was one where you really sort of did put your underpants on outside your scrubs that day. We went for as stiff a construct as we could produce to create, really, with DHS and a couple of cannulated screws, just to allow some guided collapse, hopefully, and compression across the fracture site. Trying to employ some of those things that we were talking about earlier, and that's why it's so important to understand those basics when you're thrown up against something like this. So he goes on to heal that remarkably. I mean, he had no right to heal that femoral neck fracture. And for mine, I did tell him that he would probably need some sort of revision surgery on that, but he went and healed it. Secondary bone healing down here, primary bone healing up in the neck. Really profound callus formation, but probably a little bit shorter than we'd expected, about 4 to 6 centimeters. This was pre the merger, so we had a bit of a fight on our hands to try and allow us to use the technology that we should be allowed to use in an MTC like we work in, to allow us to give him his length back. So this is post-op exchange nail to a precise, a couple of extra blocking screws. You can see the nails changed. You can see the female and male parts of the nail. You can't quite see the motor on this, the motor and the magnet on this projection, but you'll see it in a minute. Osteotomy down below. We've gone sort of metaphyseal here. You don't have to go metaphyseal with precise, though. You can pretty much put it wherever you want, as long as you follow the rules in terms of length. And this is how he went. So he's that good now. I think he's returned to his nefarious ways, and the magnet's gone missing, and no one can get in touch with him. But leg length's pretty good. When you're doing these length of corrections in the distal femur in particular, it's imperative that you get the knee, keep the knee moving throughout. He got to probably about halfway through his lengthening when things started to stiffen. And the other thing you've got to be aware of is whether you actually drive them into whether you create a deformity. Well, we managed not to. Managed not to, but my colleague Mr. Peterson will, if we get the chance again, we'll talk to you about reverse planning these to make sure that you put your blocking screws in the right places to avoid any complication. And there we go. So sure there's a few questions there, Rumina. I don't know if we should cover those.
Sorry. Okay, so there was a question about bone defects. Is there an algorithm you use in terms of size, whether you decide to go for acute shortening, or if we decide to go for bone transplant, mascule, or other sort of options like free fibula graft?
So, I mean, in essence, no. If it's going to be sort of 2 centimeters or less, about 2 centimeters in the tibia, I would perhaps consider going with a shortening and then lengthening Elizabeth, or potentially even a precise at that stage, as long as it's a sterile canal. That said, we've had some experience with shortenings that the docking site, for want of a better word, is a little bit more brittle. So we'd perhaps do more transport than we do shortening. Having said that, the next question will be, how much can you shorten? And you can pretty much shorten how much you want to. We did one recently, or I say recently, he's cooked on his left leg and he's ready for an exchange nail on the right to allow him to do some lengthening. We shortened the guy about 8 centimeters over a tibial nail with bilateral open tibial fractures. He'd had a malunited tibia on the right side. We shortened him up that 8 centimeters on the one side and lengthened and did bone transport on the other side into a defect. He's doing remarkably well. We'll probably have to do his lengthening on the shortened side in 2 sittings though, because I don't think he'll be able to tolerate 8 centimeters in terms of stiffness of his ankle, but we'll see how things go. But yeah, so there's no real algorithm. You just have to try and sort of make a decision on the table. Well, not on the table, because more often than not, you have a chance to do some planning for these cases. But if at first debridement you can shorten and get contact, that's fine. If you leave a defect, that's fine. You've got to be in a position where you can, or have colleagues in a position who can manage those situations for you. So there's no algorithm in terms of shortening or transport. Masculate, I don't masculate tibias. I might masculate a contained defect in a tibia, so a bit like that one that we saw. I might put a drop of cement in there just to stop a hematoma forming, really, and stop any chance of infection developing. But if it's a segmental defect, no masculating the tibia. Masculating the femur seems to work quite well in my hands. I've done a few, both as a fellow and as a consultant, which seem to have worked quite well. You've got to think about where you're going to get your bone from, so that's probably pushing it. That was quite a big volume there. So anything bigger than that, and you've got to start thinking about clever ways of transporting into the defect, maybe shortening to allow you to do some masculate and some bone transport or lengthening. So it's just almost suck it and see, really, to a certain extent, and try and make the techniques fit depending on whatever situation you may find yourself in. But again, you tend to have a bit of time to plan these, discuss them with colleagues, and work out perhaps how you think the patient may best tolerate it. It's difficult to assess patients, so more often than not, in the acute side of their injuries, just because they're so bloody sore and on so many painkillers. So no algorithms. It's just really a question of planning and thinking.
Another question was, how early can you go back to grafting in a masculate technique?
I think his original papers, he talks about 4 to 6 weeks as being the prime time to go back. That's when everything's vascularized and going at it. It's never really a problem of going too soon. It's probably a problem of going too late to a certain extent. I think the nature of the membrane is supposed to change after a couple of months, so you lose that window of opportunity.
Okay. And then the other question was, when do you choose to use calcium sulfate or phosphate in these scenarios?
Don't use calcium sulfate or phosphate for acute fractures at all. But don't use calcium phosphate at all. Calcium sulfate stimulant we use for void filling when we're managing infection. And again, that's probably not for this forum, but we can talk about infection another time if Mike wants us to. Okay.
Thank
Right.
you.
Well, thanks, Ben. That was a really great talk. And I think, just by talking around cases, and that's the sort of thing you'll get in the Viva, is that you'll get an X-ray up, and I think you just gave some really great principles there. So really appreciate you giving those 3 talks. What we're going to do now is we're going to go to the MCQs, and I'm sorry for those people watching on YouTube Live. You unfortunately can't see these. I'll launch the poll. As you know, all 9 questions will come up. So you go through it at your own pace and answer them. But Ben will actually go through and read the question, and then you read the answers. He'll give you sort of 30 seconds between each one. And then we'll launch the poll, tell you what the distribution of answers, and Ben will give you what the right answer was. So That's now launching. So Ben, do you want to go through now and start to ask those questions?
Yeah, so question 1. What effect would doubling the diameter of a solid intramedullary nail have on its torsional rigidity? So what effect would doubling the diameter of a solid intramedullary nail have on its torsional rigidity? Would it have A, no effect, B, a 2-fold increase, C, a 4-fold increase, D, an 8-fold increase, or E, a 16-fold increase? So we'll move on to question 2. Which of the following would not increase the stability of an external fixator? A, increasing the diameter of the pins. B, increasing the distance between the rods and the bone. C, increasing the number of pins. D, increasing the space between the pins. E, placing the pins in different planes. So which of the following would not increase the stability of an external fixator? Increasing the diameter of the pins, increasing the distance between the rods and the bone, increasing the number of pins, increasing the space between the pins, and placing the pins in different planes. Question 3. The pull-out strength of the cortical screw can be, should be not van be, excuse my typing, can be increased by A, changing to a larger core diameter, B, changing to a smaller outer diameter, C, using a self-tapping tip, D, changing to a finer pitch, or E, adding a locking head. So that's number 3. The pull-out strength of a cortical screw can be increased by A, changing to a larger core diameter, B, changing to a smaller outer diameter, C, the addition of a self-tapping tip, D, changing to a finer pitch, E, adding a locking head.